moderator of our next panel is, I think, the most popular person at NCQA. And that's because everyone at NCQA, every work group or project team wants to do right by health equity. Our Director of Health Equity Programs is in charge of making sure that happens across the company. And we are blessed to have a collaborative, patient, collegial advisor in Dr. Brian Buckley. Brian will tell you about the panel, but please give him a hand as he and the panel come to the stage. Dr. Brian Buckley.
Man, I feel like I need like a hype man like Andy like every morning, like to have such a wonderful introduction like that. Well, welcome everyone. How's everyone doing? We're near the end. It's the afternoon. How's everyone doing? Pretty good? Yeah, there we go. So as Andy mentioned, Brian Buckley, he, him pronouns, and Director of Health Equity Initiatives, overseeing a lot of our enterprise work around health equity. And I have the wonderful pleasure of moderating this wonderful panel really on the role of hospitals, health systems in this work on how we're addressing health inequities. Many terms, hospitals, health systems, even associations for hospitals have been really listening on the front line. I think I've heard themes throughout the day around how do we think about internal culture? How do we think about how we actually partner with the communities overall? So, without further ado, one thing that I know about this panel in our preparation call, you guys probably heard it when we did the webinar, I tell this to my students so many times, is the cost of life tuition is really expensive. So take these scholarships that my wonderful panels are gonna give you about the lessons learned, the bright spots, the challenges, because all of that is important for you to know, no matter if you're in California or anywhere else across the country. Understanding that you are not alone in this journey as we're talking about health equity. There are so many things that you can get out and words of wisdom you can get from our panel members. So I'm gonna have our panel introduce themselves because I think they can introduce themselves with so much more justice than I can. And let's see, I'll make sure there's nothing they have to disclose. And I also mentioned our learning objectives. We're gonna talk about be real about talking about what some of those barriers are, and really how do we also engage in leadership in this work as well. So with that, I will pass it over to Dr. Williams.
Good afternoon, everyone. And I am Dr. Michelle Williams. I'm so honored to be here with you today. I'm the Associate Chief Nursing Officer of Academic Patient Care, Clinical Trials, and Health Equity Research at Stanford Healthcare's Adult Delivery System in Palo Alto, California. I also hold dual appointments at Stanford University School of Medicine as chief, a founder and inaugural chief of the Nursing Research Section, and clinical assistant professor in the Division of Primary Care Population Health in the Department of Medicine. I'm also the founder and president of the Stanford Medicine Black Nurses Association, chapter of the National Black Nurses Association. Again, I'm really excited to be here with you today to have this very intentional conversation about health equity, particularly what is needed across a healthcare system and a hospital. Thank you.
Thank you. Traco.
Good afternoon. My name is Traco Matthews, and I am honored, thrilled to be here, have this opportunity to share in a conversation. And I am the Chief Health Equity Officer at Kern Health Systems. Give a whoop if you know where Kern is. Oh wow, that was more than I expected. I also moonlight as a professor of various different things at California State University, Bakersfield. By random life selection, also a senior pastor of a church in Bakersfield, California. And you know, I'll share some key takeaways at the end, but really the theme in terms of the interface that we have with providers and our employees, all of the domains that we touch in this health equity space is kind of belonging, because we know how important it is to the success and or failure of the interventions and the systems that we try to establish or execute. Honored to be here.
Go for it.
Hi, everyone. I am honored to be up here as part of this great group. I'm Ash Amarnath. I'm the Chief Health Officer for the California Healthcare Safety Net Institute. We are the programmatic quality improvement health equity arm of the California Association of Public Hospitals. So we represent the 17 designated public hospitals and University of California Health Systems in the state of California. And my background is in acute care surgery. I'm trained as a general surgeon and have been in this quality and equity space for the past 10 years, and I'm very excited to have this conversation here today.
Thank you all. So a round of applause for our panels as we get into this conversation. So let me get comfy here. Because we're going to talk about, we're going to start off by talking about the pebbles in your shoe. And for some of us, they're pretty big rocks sometimes in the work that we're doing to advance health equity. And so I will start with you, Michelle. And you were coming from this academic. I like to, us pracademics, and I'm noticing there's a couple of pracademics here, really seeing what's on the ground. But I want to hear from your perspective, what are some of the pebbles that you're seeing?
Sure, so that's a really good question. I will say this. I come from the healthcare domain. I spent 30 years at Kaiser Permanente in healthcare and nursing operations. I was chief nurse executive and also national director of technology research and innovation for about 10 years. So I just want to set sort of the stage here that my background is in healthcare. Part of my time was also spent at a county hospital in Oakland, California, Highland Hospital, for those of you who are familiar with that. So that was where I got my start in nursing. And I've been at Stanford for the last 4 years in my current position. So Stanford is obviously very different from those other organizations that I mentioned. Different patient population, different in terms of its geographic location. But honestly, what I've experienced over the last 4 years is the similarities. Similarities start with the fact that we're taking care of sick people who come to our organization seeking care and with the expectation that they're going to receive quality care. I sort of straddle the fence with the academic institution at Stanford, but I am fully funded by the hospital, and that's where my research and my team sits. The pebble in my shoes, actually it's an interesting pebble because in 2021, March, an issue arose among the Black employees at Stanford Healthcare. They raised issues particularly around feeling very disconnected to the organization, and we can all sort of reflect on that time in our history with COVID, with social injustices and so forth. And I was asked by our chief executive officer and president to assist with sort of finding a solution for some of the concerns that they raised. Interestingly, and also not surprisingly, some of the concerns that they raised were not just about themselves, rather it was about our patients. They were very interested and concerned about the care that they felt our patients received and didn't receive. So in spring of 2021, we launched two things simultaneously. We launched a DEI program that I was charged with, and also we stood up health equity. We started with our health equity research division that reports to me, and that's grown significantly over the last 3 years. There was a lot of sort of similarities between both efforts. What we realized, and this has been widely published, is if we don't address workforce inequities, we're not going to solve patient and healthcare inequities. And we have actually seen this come to fruition over the last 3 years, where we have progressed some very strategic projects and programs within our workforce equity team. I wanted to do something differently. Instead of the same sort of approach to solving problems, where people get together and they talk about them, at the outset, in March of 2021, one of the things that I proposed in my very first meeting with the CEO was that we used a human-centered design approach to addressing the concerns of our Black employees and allies. I thought this was important because one of the things that hadn't happened in the past was sort of an appreciation for the lived experiences of the employees, not just outside of work, but actually their lived experiences in their work settings, what they were going through, what they were seeing, what they were hearing, what they were experiencing. And we're now 3 years after that. And I'm so honored to tell you that we've implemented 3 what we call bold moves, and it's really changing the paradigm. So 3 years ago, people didn't feel connected. Right now, people feel empowered, and they are leading the cause. One of the major things that they implemented was what we call an equity award. You've heard of, the DAISY Award and other kinds of awards across healthcare systems. Well, this award it has its foundation in identifying and appreciating when equitable care is delivered, when there's an opportunity to call someone out for doing all of the right things. The goal is to educate and to support that progressing across the organization. So this is a pebble that I'm very proud of. What I found to be most important in this work is for our organization to put their money where their mouths are. And the best thing that our president and CEO could have done, and at the same time the worst thing that he could have done, was to call me and ask me to help. Because I've completely leaned into this, and he said, let me know what you need in order to get this done. And I did, very clearly. And I will say that I'm excited to share that I asked for $1 million, and I turned that money into seed funding for research directed internally at our healthcare system, our patients who come there for care, practices that we need to change, in the tune of more than 45 individual DEI and health equity projects. So I'm excited about that, and there's so much more work that we have to do. We are not near where we need to be, but I'm excited that we've gotten this far. Thank you.
Thank you. Yeah, you guys can clap for that. And I think that's an important piece that we mentioned here, because I want people to just remember is, as we've been talking about health equity, a lot of our panels have been talking about the external work that we're doing. But I've always kind of constantly said, to do really good external health equity work, we need to make sure that we're also doing some really good internal health equity work, and making sure health equity isn't just one person's job, but it's woven throughout the whole entire organization and everyone can speak to it. So thank you for sharing that. So we're going to shift to you, Traco, because I remember you had a couple pebbles that were kind of related to some of this on some of those courageous conversations.
No, thank you so much, Brian, and excellent response there. I'll touch on some of that, but I've been fighting pebbles all my life. Growing up in the Central Valley, and as part of our health equity roadmap, our strategy, we've identified kind of 4 key domains, and employees is the first one. Of course, our providers, the hospitals, the clinics, everyone that we interface with, our members, of course, but then also our communities, because sometimes we can try to move the needle in all of these other spaces, and the drag from communities is still too great to bear. And really, the pebbles are in all of those domains. So as you were mentioning, Doctor, some of the challenges within organizations, I'm newer to healthcare, but it wasn't surprising for me. I knew coming in as a chief health equity officer, I've worked in private corporate sector, I've worked in government, I've worked in the nonprofit sector, and what I've discovered in terms of lived experience is that across the board, there's that pebble, that difficulty really of systems and organizations sharing 3 things. And those 3 things are power, resources or just money, and often voice, legitimate, authentic voice, being willing to have people come in and maybe shake things up. And so coming into the organization, I knew that's probably my unstated biggest challenge that I'm gonna have to face, even potentially from folks who I'm working with, colleagues, at all levels of the organization. Because there's just this natural human fear of new folks coming in and belonging and then getting to change your strategy that you've been doing for a long time. And I did run into some challenges with just my position. And so there were a couple of folks, I won't name any names to protect the guilty, but there were some folks who pushed back pretty hard. And I was expecting it because I've honestly encountered it everywhere I've ever been. And as soon as you say, hey, you know, whoever initiates the change, whether it's the CEO or an external force, a governing council or body or regulatory agency, folks almost always move to fear first when it comes to, oh, we're going to have new folks helping us inform our strategies on health equity, on quality, on anything. Why are you here? We were doing a pretty good job before, I thought. I've been in this role for however long. And so because we interface from a health equity perspective with so many different domains, we're talking about culture change. And I recognized that pretty quickly. I was like, okay, culture change is always difficult because it can mean some pretty big changes. It can mean a lot of vulnerability at all levels of an organization, including our boards and so forth. It can mean a lot of humility. And so in order for that to be successful, any of the domains, we have to acknowledge, okay, where are we gonna probably struggle with sharing power? All right, decision-making power. And an easy way to say, I can't remember who mentioned it in one of the earlier panels, but you can usually measure that by the level of diversity you have in the C-suite. And that's a demonstration that you are willing to share decision-making power. But across, again, all of those 4 domains, I knew that's probably where we're gonna run into the same pebbles and struggles as before, and we did. With our governing board and really who are in place with our Board of Supervisors in Kern County, which is a very conservative county. I knew coming in, there might be challenges, and we'll have to be delicate and nuanced about how we approach this, because my approach that I believe has been somewhat successful, you know, I'm a pastor, so I always want to call folks in instead of calling them out, and that has mostly been successful, and it's been successful with Kern as well so far, but not despite the pushback and the challenges with sharing of power, with investing differently, you know, in communities or with employees, and how we develop, you know, minority groups or female leaders, et cetera. And so those are the pebbles that I have run across in my experience, and they were expected.
Thank you for sharing. I mean, I think we see that so much, and I think folks, I'm seeing a couple head nods and a couple of smiles where it's like, you know, everyone wants change, but they're like, don't tell me to change. Like, I've been living really nice, and often, which we talk about in the literature, people live in their own halo. Everything was going great. Like, yeah, we have our challenges, but we're doing really good, and really that cultural shift is so hard. So thank you for sharing some of those lessons. So Ash, you might have a couple pebbles since you work with a lot of different folks, and you might be having those pebbles kind of go towards you. So could you share what pebbles you're dealing with?
Yeah, absolutely. So I think if you rewind 10, 15 years ago, a lot of the pebbles came from lack of awareness, lack of understanding, and getting the right people on board. But then as we went on our road towards health equity, there's other pebbles that kind of came up along the way. First part is siloing health equity as something completely different, or that by hiring a chief health equity officer, you know, Traco's going to fix everything, right? And so the box is checked, and you don't have to do anything else. So it's back to that change management aspect that you both were speaking to so eloquently. And then it's also then even when some of the silos were breaking down and you're starting to see health equity as a lens of quality, It's a bigger picture than that. Health equity should be a lens for all the operational functions and pretty much everything that we do in healthcare delivery. And so it has to move beyond just disparity reduction, although that's extremely important. Data collection is extremely important, and being able to improve the care that we give to all of the patients that we serve is extremely important. But to create that sustainable change, it needs to go deeper than that. And it needs to address the organizational structures that we've built. Luckily, and I don't mean to go into bright spots a little bit, but I will. We received a California Healthcare Foundation grant, so thank you, CHCF, to work with the National Equity Project and build community of practice among our public health systems. And that, I'll talk about that more later, but it's really gone a long way into breaking down some of the infrastructure, dismantling it, and co-designing and building the healthcare delivery system that we all want to see and that our patients deserve.
Thank you. So I'm going to throw a question there because I think you actually bring up a really good, interesting point. I'm curious, Michelle and Traco, how this is also works. I think this actually came up in an earlier panel, but you said something important that often sometimes, health equity is in its own silo sometimes. And for the folks that were at our Health Innovation Summit, one of the panel, the Health Equity Trailblazer panel, they were talking about that. Sometimes health equity is used as this service line where there has this revenue. I think the most often question I get is, what's the return on investment? And so I'm curious on how is health equity being operationalized at your organization, especially, Michelle, as you talked about research that you are also doing. So you have this combination of a couple of things. What does that look like? Anyone can kind of answer that or start off.
So I'll jump in first. One of the first things that I was asked to do immediately after I was funded for the health equity research team was to look at the operational plan. This was in April of 2021, again, right after this major investment had been made. And it was on a Friday. I was given the operational plan and draft. It was the draft that had already been written for the following year. And I was told that I had until Monday to get it back to the team. And the question that was asked at that time was, should we put health equity on this as a title, or should we put it in these different areas? And before I received the email, I said, health equity should be embedded in every single thing that we do. I said, so I want to warn you, when you get this back on Monday, it's going to be marked up in red everywhere. And he chuckled. Well, I took it home and I looked at our operational plan. It's broken into 4 domains. Historically, before I got it, it was quality, patient experience, employee engagement, and finance. When I sent it back on Monday, I changed quality to quality, safety, and health equity, because what I realized, and I think we can all agree on this, is you're not going to achieve quality or safety if you don't have health equity. You're just not going to do it. The other thing that I realized a year before this conversation was that our data systems weren't and aren't currently completely structured in a way for us to get demographic data so that we understand who the populations are that we care for. So what I also decided was to push our organization to a strength, and that was by adding a goal to that quality, safety, and health equity domain, indicating that we needed to identify health disparities in all quality and safety metrics, and for that first year, fiscal year 22, that would be our baseline goal. I will tell you we've done that. This past fiscal year 23, first time ever in the history of Stanford medicine, we've produced about a 200-page document that reflects all of the healthcare disparities across all data at Stanford Healthcare for the past 5 years. Yes. I mentioned that I spent 19 overlapping years at Highland Hospital. And I didn't grow up in that area. I grew up in a very different, a suburb, but wanted to go to Highland because I was very committed to providing care to people in communities that needed someone who really cared. Not that other people didn't, but I really wanted to be there. And the years that I spent at Kaiser. So in my role at Stanford, I'm post-retirement. I have everything to gain, nothing to lose. So I'm at a point where what we need, I will pursue. So that fiscal year operational plan also has embedded in it throughout every single domain, health equity and DEI goals. Another one that I really felt was important, again, I oversee clinical trials research. These are, more than 7,500 clinical trials that get deployed across Stanford medicine annually in the adult care delivery system. My team oversees every single one of them. I have access to every protocol. I have access to every enrollment plan, recruitment plan, everything. So what I also wrote under patient experience was that we needed to increase access to communities of color in clinical trials. And I produced the data to demonstrate why that was important and the fact that we weren't doing that. And also, when that was presented to our board, our chairs, our physician chairs, there was some concerns because an operational plan, as you all know, it's our commitment. It's not just like a mission statement. It's our annual commitment that's incentivized. And if we're not meeting those targets, we're called out on them. So it was really important to me. I knew that we could not implement health equity without it being sort of in our faces, and that's where it is right now. And I'm happy to say that we're moving the needle, which is something I'm proud of. Cool. Thank you.
Thank you. You guys can clap on that one. And so, Traco, Ash, anything to add on what Michelle's doing, how that relates to your systems and your organizations on how you're working?
Well, first of all, let me just say I'm incredibly jealous of what you all have already accomplished there. No, that is phenomenal when you talk about having it already incentivized and across, departments and the entire system. We're a bit newer, so we don't have the same muscle memory as Stanford. However, there are some wins that I think we have seen in Kern already. In the year that I've been there. And the first one is just this when it comes to quote unquote sharing power. So I actually am in the C-suite. And a lot of plans, I'll say some plans, their health equity work, officer, et cetera, is not. And that's challenging because everything you hear at some point gets distilled by the leadership that it's filtered through. And so if you're not at the table helping to inform the decisions of the finance or your CFO and the CEO and everyone who is making these critical decisions for all of your members, patients, et cetera, that's a loss. And to me, having your CEOs, that's what we call ourselves, in the C-suite is a first step or solution towards sustainable success. And so that's a win. I also at least got funding for some bit of a team. I know that some folks, it's the CHIO, and that's it. And so again, sharing, being willing to share some measure of decision-making power and invest. This work will not be successful if we do not invest in it. Financial resources, time resources, et cetera. And then the rest of it, we are continuing to build, as I mentioned earlier, in all of those domains. So right now we're developing DEIB trainings for our employees. Of course, the APL said you have to, but it's a marriage of choice and mandate, which is also a win. That's a good thing because it gives employees who get to be part of these DEIB programs once they roll out, it gives them a higher sense of belonging when the organization says, we want to do this, not we're doing this because mom made us, all right? It just never hits the same way. So across domains, as we are building our roadmap and our strategies and our metrics of success in Kern, we're approaching it from that perspective of, well, how is this going to make the stakeholders, the constituents feel in terms of their sense of belonging? Are we truly sharing power in terms of our structures, and soliciting authentic voice and feedback, qualitative feedback, so that we can be successful for the long term? But one day we will hopefully be in the same place as Stanford. That is a vision.
Thank you.
I'm always looking for partners, so feel free to call me and join and we'll support you.
Thank you.
Ash, anything to add to that?
Yeah, the one thing I would add is these are phenomenal examples of balancing the moral case and the business case for health equity. And I think that's a critical step in being able to build that infrastructure. What did you call the position? Was it a CHIO?
CHIO.
Yeah, so I
know, it
think,
sounds cool too,
yeah,
like
I know,
CHIO.
it's really cool. So having your CHIO in the C-suite is great, because that's where you have access to the ears and the eyes and the resources that you need to be able to do the work you're done. And that's the type of balancing act that you need, or the infrastructure change that you need to be successful in a sustainable way.
So now we're going to shift it to the bright spots. I promise I'm going to get to the bright spots. These are the moments where, you can really kind of do a shameless brag of what you feel most proud of that your organization is doing. And so we're going to start off with you, Traco, on what is something that you're proud of that your team has done, a win, a bright spot.
So we have a lot to be proud of, I would say, and I'm going to speak from an organizational level, because as we've been saying, everything that my team does, everything that we do, if it's not impacting the entire organization, if it's not impacting our entire system, it's really not achieving the goal. But one of the things that we helped to drive and influence is in the community's domain. So we've done work, but trust is critically important when it comes to how we interface and work with CBOs, community-based organizations, and just how we work with community partners. And one of the things that we did recognize is that, Kern County has a lot of disinvested communities. And sometimes it's because they're rural, and so folks just kind of forget about them, don't think about them, or it doesn't make a lot of numbers sense, speaking to that moral case, to invest, quote unquote, a whole lot of money into something that is not going to give you a whole lot of numbers. But we recently invested $20 million. Our board made that decision, a strategic initiatives decision to invest $20 million in communities. Now, that was a mix of providers, FQHCs and the safety net, but also a chunk that we had never before even thought of for actual community partners. And we also started a health equity partnership, the Kern Health Equity Partnership, KHEP. I have some folks here in the audience who were very instrumental in that work, because we understand that this work really is bigger than all of us. And when I say that, I mean even bigger than the health system in Kern. If we don't have education at the table, it's almost useless. We think about wellness, child wellness visits and so forth. And you have to have so many other partners at the table, because really what we're trying to do with this work, I always say my mission in life is always the same: change the world. And you can do everything within your power in your own system. But if you're not humble enough to understand that this also probably means culture change across the landscape, wherever you live, you're lying to yourself. So we're proud of the work that we've done from that structural perspective, but also from the investments perspective. And I'm just excited because I know there's more to come.
Thank you so much. And Traco is true to his team. I got to see the whole team, and so definitely a shout out to the Kern team for all that work. Ash, the bright spots. You were waiting for this one.
I was waiting for this one. So there's a lot that to be proud of, and that being said, there's also a lot more work to do. So thinking about it from the quality improvement perspective, I think one of the things that is a huge bright spot is demographic data collection, which has, in the public hospital space, has improved. Real data has improved almost double in the last 5 years in being able to collect self-reported data. And SOGI data, which is incredible, went from 7% to almost 81% data collection. So that is from the quality improvement perspective, because having that data lets you identify disparities and then put the work and effort into reducing those disparities. But moving beyond from the structural point of view, I'm most proud of the community practice work that I've seen our systems engage with, and it's making those uncomfortable conversations a reality, and leaning into that discomfort to actually redesign the way the organizations are structured, the way they hire, the way they workforce is representative of the patients that they see, and all of the policy decisions they make. I think just seeing that work, even though it's in its infancy, just seeing that work get started is a huge bright spot.
I like that you mentioned that one value, of the value of leaning into discomfort, because a lot of this health equity work is uncomfortable. It's different. You know, we haven't ever been in an equitable society, so I think that's definitely really cool to see the work that you guys are doing in that space. Michelle.
So I think this is a really great question, and I mentioned earlier that I'm the founder and president of the Stanford Medicine Black Nurses Association, which is not by chance. In 2020, as the world was, fighting so many demons, and we were dealing with a lot here across the United States, particularly around social injustices, health inequities, I realized that at Stanford, in the hospital system, we really didn't have the infrastructure to conduct the kind of research that I felt was needed. I had a team of 3, including myself. I was the only person that looked like me, and I realized that I needed to align with an organization that was much larger than myself. So it was at that point that I reached out to the National Black Nurses Association. They had published a lot of very compelling research in the previous 6 months, and I had one question for them. 1, are you willing to partner with me? They said yes. I said 2, can you help me create a chapter at Stanford Healthcare? Because I really felt that that would not only give me a partner in the research space, but also start to help us, Stanford, as an organization, to move the needle around equity. And this relationship with them has been incredible. Not sure if you've seen this in the news, but one of the things that I was able to help influence through research is moving the National Black Nurses Association conference from Hollywood, Florida to San Francisco. At a loss of $562,000 to the National Black Nurses Association. I was also able to get support from Stanford Healthcare to donate a large portion of that to support and offset that loss. I'm really proud of that. So some of the bright spots are education, influence, and building knowledge. From an educational standpoint, I knew that in order to really influence the organization, that hospital nursing, academic nursing, and I have about 10, 15 PhD prepared scientists on my team, I knew that I needed to have a footprint at the School of Medicine. So I was able to influence launching the nursing research section and serving as its chief. Because I invest in the School of Medicine by funding the faculty positions. The benefit there is it really puts us on the map at a prestigious organization, a research chief, Black woman, registered nurse, who's helping to drive and influence health equity across the organization. So I knew that that would be an important position for me to take. And finally, our interns and residents came to us, my health equity team, and our chief medical officer, after we sent out an article broadly across Stanford about the bias in algorithms. And they wanted to know what that meant for them as soon-to-be, practitioners. They wanted to make sure that they were practicing equitable healthcare. They're very concerned about that. So I ended up being on this panel, the only nurse, mostly physicians, and they had about 32 questions that I had my team answer before the panel, and shared that with them. That eventually turned into a webinar, and it is now a perpetually available webinar course that anyone can take. It's on the history of racism in medicine. I am so proud that I was able to put that together. It goes back as far as time, where we have documentation of all of the things that have impacted in a negative way healthcare, medicine for communities of color. It also points out bright spots, people who are willing to fight the system to do things, to try to make things better. It also led to me being asked to serve as a PI on an FDA-funded pulse oximetry study where we're looking at the differences in measurements for patients of color versus non-patients of color. And I'm really excited about that. We're about to publish our findings, and it's gonna make a difference. I mean, if we find that there is a difference, then there's an opportunity for us to build a better tool. So I'm really excited about this. We've published a number of articles, really invested in research, but not just for the sake of doing it. Because we're in the health system, we're taking our findings where we've identified best practices and looking at ways to change our system. One big thing that we did over the last few years is we've eliminated the estimated GFR at Stanford Healthcare. And today, I believe JAMA is publishing our article on that. Thank you.
And also want to make a note, because I forgot to mention it before, and this is an incentive for all of you guys to look at the resources that are available to you for this conference, is we do have slides for all of our panelists that have resources that they have put out and the different ways of things that they've talked to. So a lot of the articles that we're mentioning, they will also be available to you. So I want people to start getting ready for any questions that you might have. I'm going to do a rapid question, because I like to end off with hope. And any piece of nuggets. I talked about the scholarships that you guys can give to them. So as folks start coming up to the mic, we'll start doing the last question I have is, what piece of wisdom do you have for people that are just getting into this work? We have people that are here at this forum. Some of you are like, this is new, that you're jumping into this for the first time. And we have some that are veterans. What's one piece of advice that you would give folks as they are going on this journey? So we'll start over with you, Ash, and then work our way up. And then if people have questions, you can start heading to the mics.
Yeah, I think the biggest piece of advice I would give is that you're not alone in this work. It's important to collaborate, find those connections and collaborate. And think about it not just with, if you're a health system, not just another health system. If you're a health plan, not just another health plan, but collaborate across the spectrum of care. Because that's where the most progress is going to be made. And then be intentional in the work that you do. Think about the end goal and be intentional in the structural changes you make and the quality improvement projects that you take on.
Thank you.
The advice I would give is similar from this perspective. Be committed. Don't start down the road if you don't plan on being resolved and seeing it through. It's going to be difficult. Go in with your eyes open, no matter where you're interfacing with this health equity work, because again, it's going to be challenging and scary for a lot of folks. So be committed from a Yeah, it's a good business model and practice, but also we've got to have that level of conviction and heart in order to be successful in this work.
Thank you. Michelle?
Start small. I've shared a lot of big things that we've been able to do, but I will tell you that it was like pushing 5 boulders up a hill. This was not easy. Start small. Find those grassroots initiatives that are happening just below the surface within your organizations. There are people out there who are doing small things, and see how you might support them, and find support. I knew that I could not move the needle with research without a major organization supporting me and helping me do that. So find collaborators, join groups that are out there. These are some of the things that I've done, and they've been incredibly helpful.
Thank you all. So it looks like we got a line here of questions, so making sure there's no one on that side, so we'll start right here.
Good afternoon. I'm Annette Holmes. I'm from Centera Health Plans out of Virginia. A question for Michelle. You talked a little about data, the bias, and the delivery. Where do you start as far? We're new. We just attained our health equity accreditation. So where do you start identifying bias in algorithms?
Thank you. That's a really good question. One, there's a lot of research that's been done. I mean, if you put those 2 terms together, you'll find it. I found a whole list of it. If you want my list and those 32 questions that we answered, just email me. I'll send that to you. But one of the things that we did at Stanford was, one of the things I did was I just met with all of the data owners. I wanted to know who's capturing, data around health equity, around health inequities. What data is it that each of these different groups had, and is it accessible? So I just started there, just gathering information, and what I identified was just a lot of roadblocks that that information wasn't easily accessible. I couldn't get to it. When my team and I evaluated safety and quality data using sort of demographics and other specific data points, it took a long time. It took us 6 or 7 months to clean it. It took us a long time. There was a lot of missing data. We're just sort of moving through implementing our real sort of structure within our EHR, SOGI. So there's a lot of missing things. So be patient, particularly if your organization is not already set up with those structures in place.
Thank you.
Thank you. Second question.
Hello, Grace Ting, Elevance Health nationally, and here in California, Anthem Blue Cross. And my question is for any of the health systems or providers here today, is that when you're thinking of health plans, how would you like to see us operationally support your health equity and diversity efforts, and vice versa? What can we do to provide bi-directional data exchange, sharing of resources, collaboration? I think you mentioned collaboration a lot. We'd like to add value, and you're much closer to our members, because they're your patients. So love to hear your thoughts on that. Thank you.
I think Ash or Traco, or who wants to take that?
Well, excellent question. Thank you for that. And I promise I'll give you time. All of the above is the answer. Bidirectional data exchange would be phenomenal, but there's a lot of barriers to get there. I think showing up at the table is number one. If you're willing to have regular meetings with our health systems and really having those difficult conversations about where are the gaps and how can you work together to fill them, rather than working in silos separately. I think just showing up and being willing to cooperate and collaborate is the best thing that any health plan could do for a health system.
Yeah, and I'll add to that. So I meant to mention it in my slides. I put a couple of graphs there to talk about how hard this work is. The best way to diversify your workforce is to diversify your C-suite. The best way to diversify your C-suite is to diversify your board. But again, that's really difficult. Again, power is hard to share. So I would say wherever you have influence, make the decision. The graphs that I put there, from 2020, and it was a survey of 5,000 hospitals, and I think across the board they said 84% of folks understand the need for DEI, for concordant care, for all of these things, and still their boards look like they did 30, sometimes 40 years ago, or not much different in terms of who's at the top. So wherever you have influence, make decisions to diversify, and I think that will help to change your outcomes in years to come.
And we have one last question.
Thank you for being here. First, I want to thank you for the amazing work you've accomplished. And I think a common thread across the panelists has been really looking forward to the impactful opportunities that we can support. And with that, I typically make an invitation. I think many times we talk about underserved, minoritized, de-invested communities. And I think the common thread is that we are working with historically resilient populations. And I really like to elevate that term and invite folks to think about that term when we describe our populations. Now, the question is, for folks who are not in the C-suite, who are still working through the navigating complex organizational structures and conversations on resource management, can you share what the most difficult, crucial conversation you had when you were at that level and how you navigated it?
Who would like to take that one? I'm Leon Traco right here.
I'll share. So, I'll be honest. I've had a couple of conversations in my career, I'll say a handful, where going in I thought I could be fired at the end of this conversation. It was that tough. One was probably about 10 years ago. I was working for an oil company in Kern County, because oil and ag are big. And we were just talking about the whole concept of diversifying enough to include an Allies Plus employee resource group for LGBTQ plus staff. And I had, someone who wanted to start that conversation, but they needed support. And so we went to the CEO and we said, hey, our system has a bias, it has a problem. I was more in tune with that bias because I'm an evangelical Christian who was in Bible studies, and I heard comments, and so I was like, it's even worse than you think. But having that conversation and advocating and saying, hey, our system has some biases. And I know you may not know that or believe it, but we need you to act on our behalf and give us cover. And we didn't get fired. They started an employee resource group, and now today they win awards for their work in this space and in other diversity spaces. But I think it started with that first really difficult conversation about opening our eyes and acknowledging some of the biases that we have in our systems.
Thank you. So a big thank you to Michelle, Traco, and Ash. A round of applause for our panelists. For one, keeping it real about those challenges, those difficult conversations, but also talking about the bright spots and hope. So I'm going to try something new. I'm going to end off this panel with a quote, because I think it speaks to a lot of what we've talked about. But a quote by Amanda Gorman said, "All of us bring light to exciting solutions never tried before, for it is our hope that implores us, at our uncompromising core, to keep rising up for an earth more than worth fighting for." So I hope all of you take that quote with you, take these lessons learned that you got from this panel and so many of the other panels throughout today, and use that as you advance health equity. So thank you so much. And I think we'll do one more round of applause for our panel again, because it's been pretty amazing. Thank you, guys.